Welcome back to the Deep Dive, where we take complex foundational source material and really transform it into high-impact, actionable knowledge for you. Today, we are undertaking a deep dive that is, it's truly the bedrock of modern surgical care.
It really is.
We're looking at Chapter 23 of Baily and Love's 28th edition, focused on anesthesia and pain relief.
And our mission for you, the listener, is crystal clear. This is a dense chapter. It covers everything from, historical breakthroughs to the pharmacology of dozens of agents, the intricacies of advanced regional techniques.
It's a lot.
It is. And we are not here to just recite the text. We're going to interpret it, simplify it, and most importantly, we're going to establish those critical mental anchors that you need.
So you can use this as a ready reckoner, a revision tool, or just a quick refresher before you hit the wards.
Exactly.
I think the complexity of this chapter, it really highlights something fundamental about modern surgery. We often think of the surgeon as the hero in the spotlight.
The star of the show.
Right. But the outcome of the race in surgery is a race, isn't it?
Yeah.
It relies just as much on the person managing the entire environment of the operating room.
Oh, absolutely. It's all about seamless collaboration. I like to think of it like a high-stakes auto race pit stop.
Okay.
The surgical team, they're handling the critical repair, changing the tire, fixing the engine damage. The anesthetic team is the other half of that crew.
Right.
They're ensuring the driver, the patient, remains stable, optimized, and alive through the whole process, ready to finish the race. If one half fails, the whole effort just collapses.
And this isn't just a nice idea, is it? It's a practice that's been dictated by some pretty harsh realities. I know the source material highlights several national audits that have driven massive necessary changes.
We learn this stuff through painful lessons. Audits like NCPO in the UK, the National Confidential Inquiry into Patient Outcome and Death, and similar inquiries, especially those focused on maternal deaths, they consistently show that failure often boiled down to basic errors.
Things like poor communication or just a lack of standardized practice.
Exactly that. And the findings, they didn't just recommend minor tweaks. They mandated systemic changes that forced better teamwork and, just better adherence to protocol.
So if we're talking about mandatory standardization, we have to immediately mention the most important, simple tool that was introduced globally.
The World Health Organization Surgical Safety Checklist.
That simple checklist, it's so powerful.
It's profoundly powerful because it institutionalizes collaboration. It forces the entire team surgeon, anesthetist, nurse to just pause.
To take a breath.
Yes. To verify critical steps, anticipate risks, confirm the essentials before you even start, before the incision, and before the patient leaves the room. It has been empirically proven to significantly reduce perioperative untoward events. It literally saves lives just by making sure nothing is forgotten.
So if the WHO checklist sets the team rules, the conceptual shift establishes the role. The old view of the anesthetist as just the person who puts the patient to sleep. That's completely outdated.
Oh, completely. The modern role has evolved into the perioperative physician.
I like that title.
It reflects this holistic responsibility that stretches far beyond the operating room doors. It starts in the pre-op clinic, optimizing the patient's health, managing pre-existing risks, whether that's poor cardiac function or diabetes control or lung capacity.
So it's not just about the procedure itself.
Not at all. It covers the intraoperative care, of course, but then crucially, it extends into the postoperative phase, managing pain, respiratory function, fluid balance, full homeostatic stability, all the way until the patient is safely discharged. It's a continuous, comprehensive plan of care.
Okay, so let's unpack this journey by taking a quick look backward. Before the mid-19th century, surgery was, it was almost an act of violence.
It was horrific.
Speed was everything because the pain was just unimaginable. The quickest surgeon was considered the best.
A very dark time. Infection and shock were almost guaranteed, and the patient's fear was probably as great as the physical trauma.
But then the tide started to turn. In 1844, we have Horace Wells, a dentist, using nitrous oxide laughing gas for painless tooth extraction.
And that planted this revolutionary idea that maybe surgery didn't have to involve agony.
And that idea really took hold 2 years later. The pivotal moment, of course, in Boston in 1846.
Yes, when William Morton, another dentist, successfully gave ether to a patient named Gilbert Babbitt for the removal of a neck tumor at Massachusetts General. That demonstration, the ether dome demonstration, was the public, undeniable proof that general anesthesia was possible.
But ether wasn't perfect, was it? It had flaws.
Big flaws. It was slow to act, it was flammable, and it caused terrible postoperative nausea. And that really, I'd opened the door for Sir James Young Simpson in Edinburgh to introduce chloroform.
Chloroform was easier and faster, right?
It was, but Sir James Young Simpson, he also faced this severe ethical and religious pushback. Many people believe that pain, particularly during childbirth, was divinely ordained and shouldn't be touched.
Which brings us to the most powerful historical anchor against that idea.
The royal endorsement.
Queen Victoria accepted chloroform, administered by Dr. John Snow during the birth of Prince Leopold in 1853.
And a royal seal of approval just completely shifted public opinion. It destigmatized anesthesia and made it an expected, acceptable part of modern medicine.
So this long, dangerous journey brings us to the modern definition. What exactly are we trying to achieve when we talk about general anesthesia, or GA?
It's defined by an essential triad, a three-part state that you have to maintain for the whole procedure. It's non-negotiable.
You can't have 2 out of 3.
You need all three. The pillars are amnesia, analgesia, and muscle relaxation.
The 3 pillars. That's a great metaphor for remembering it. If you picture the operating cable resting on those pillars, the moment one fails, say the patient feels pain, so you've lost analgesia.
Or, catastrophically, they experience awareness loss of amnesia while they're fully paralyzed.
The whole controlled environment just collapses into a critical event.
Exactly. Amnesia is the loss of awareness and consciousness. Analgesia is the abolition of pain. And muscle relaxation, the third pillar, is the pharmacological paralysis that the surgeon needs to get into the abdomen or the chest without the patient resisting.
Which often means paralyzing the breathing muscles as well.
That's right.
Okay, so to get that first pillar, unconsciousness, we use induction agents, usually intravenously for speed. The current standard is propofol. Why has it so completely replaced the old guard, thiopentone?
Propofol is just a remarkable agent. Clinically, it gives you a very rapid, smooth induction and a really clear, clean recovery.
Less of a hangover effect.
Exactly. It's lipid-soluble, it's rapidly metabolized, so there's minimal hangover. It also has pretty good hemodynamic stability compared to thiopentone, and it's known for its antiemetic properties, which is a huge clinical advantage.
Less post-op nausea and vomiting.
A major plus. And because you can use it for continuous infusion, it's the bedrock of what we call total intravenous anesthesia.
Are there any big drawbacks we need to know about?
The main ones are pain on injection, so you often give it with lidocaine, and it can cause a pretty marked drop in blood pressure if you push a big dose too quickly.
Okay. But the old guard, thiopentone, a barbiturate, it still has a place, right? Despite causing myocardial depression.
It does. Its niche is primarily in neurosurgery.
Why there specifically?
Because it has this potent ability to reduce the brain's metabolic rate and blood flow, which effectively lowers intracranial pressure, or ICP. So in acute trauma or where brain swelling is a concern, that action is paramount. But you have to use it with extreme care because of the blood pressure risk.
And then there's etomidate, a steroid derivative, which seems to solve the blood pressure problem.
It does. Etomidate is prized for its excellent hemodynamic stability. It's often the agent of choice in really critically ill or trauma patients where you just can't afford to lose any blood pressure.
But there's a catch.
The major drawback, is a concern over adrenocortical depression, even after a single dose. So that limits its use outside of that initial emergency induction.
And then there's ketamine, which sounds like a total outlier, a field anesthesia agent.
It is an outlier. Ketamine, it's a phencyclidine derivative, and it works differently. It creates a dissociative state, not a classic coma.
What's the advantage of that?
The key advantage is that it preserves laryngeal reflexes and maintains sympathetic tone, so it preserves blood pressure and respiratory drive. It's excellent for trauma or remote settings where your monitoring might be limited, and it's a fantastic analgesic.
The downside.
The clinical downside is a significant risk of emergence delirium-disturbing psychological side effects like hallucinations or vivid, frightening dreams when the patient wakes up. It can be extremely distressing.
Now, while IV is standard, we can't forget inhalational induction. Why is that still a thing?
It serves specific groups, people with severe needle phobia, children, and most critically, patients where you're anticipating a difficult airway.
Because if you try to force an IV and fail, you've lost precious time.
Exactly. For these patients, you use non-pungent agents like sevoflurane to gently induce anesthesia while they're still breathing on their own.
And the risk anchor here is critical.
Yes. The moment these patients lose consciousness, they are at a much higher risk for sudden airway obstruction because of their anatomy. The whole team has to be ready to act instantly.
Speaking of acting instantly, let's talk about rapid sequence induction, or RSI. This isn't your routine induction.
No, RSI is a precision maneuver. It's used exclusively for patients with a high risk of regurgitation and aspiration.
So emergency surgery, trauma, anyone with a full stomach.
That's right. These patients have a massive aspiration risk, which can lead to chemical pneumonitis and death. RSI involves giving a predetermined dose of an IV agent, immediately followed by a fast-acting muscle relaxant without any bag mask ventilation in between.
The goal is just to get that definitive airway, the ETT, in as fast as possible to protect the lungs.
As fast as humanly possible.
Okay, let's dive a bit deeper into Tiva total intravenous anesthesia. It seems to be gaining serious momentum. Why the shift, especially with drugs like propofol and remifentanil?
The shift is multifaceted. First, remifentanil is an ultra-short-acting opioid. It has a rapid onset and rapid clearance because it's metabolized by plasma esterases, independent of your liver or kidney function.
So it's very predictable.
Very. And when you pair it with propofol, Tiva lets you have this extremely fine-tuned, continuous control over the depth of anesthesia and analgesia. And because they're so short-acting, there's virtually no cumulative effect. The recovery is faster, cleaner, less complicated.
Which is a huge benefit for day case surgery, I'd imagine.
Exactly. The patients are ready to go home sooner. Tiva is also preferred in neurosurgery and in airway laser surgery to eliminate the risk of explosion with inhaled agents. And the final big driver is environmental.
The greenhouse gas issue.
Right. Volatile anesthetics are potent greenhouse gases, and Tiva eliminates that concern entirely.
It sounds like the days of inhalational agents, especially nitrous oxide, are numbered. It has weak properties anyway, but what are the specific clinical reasons for its decline?
The clinical concerns are substantial. Firstly, it increases postoperative nausea and vomiting. Secondly, and this is critical, because nitrous oxide diffuses rapidly into air-containing cavities, it can increase the size of air bubbles.
So it's a no-go in certain surgeries.
Strictly contraindicated. Eye procedures like a vitrectomy, middle ear surgery, or anywhere you have a bowel obstruction or a pneumothorax. On top of that, it's a significant greenhouse gas, and there are some concerns about potential mutagenicity.
Okay, that was a dense section on induction. If you, the listener, need a refresher on why thiopentone is dangerous but useful, or the key difference between propofol and ketamine, please just take a moment and rewind to anchor those distinctions before we move on.
We're transitioning now to what is arguably the most fundamental and life-saving skill in all of anesthesia, maintaining a patient's airway.
Let's go back to basics. Why does the airway collapse the moment a patient goes under?
General anesthesia is, essentially a controlled depression of the central nervous system. This causes a loss of muscle tone in the pharyngeal and laryngeal muscles.
So gravity just takes over.
Gravity and negative pressure. The tongue and epiglottis fall backward, and that obstructs the upper airway. And if we add muscle relaxants for the surgery, the diaphragm and respiratory muscles also stop working, so we have to artificially ventilate.
The first response is always manual head tilt, chin lift, jaw thrust. But if that's not enough, we turn to simple adjuncts.
The oropharyngeal airway, the Guedel tube. It's a simple, curved piece of plastic. Its main function is purely mechanical. It holds the tongue forward, preventing it from blocking the pharynx. It's critical for helping with bag mask ventilation.
But there's a crucial safety limit that you must never, ever forget about the Guedel.
Yes, the Guedel airway does not prevent aspiration of gastric contents. It's purely a mechanical guide. It buys you time, but it doesn't secure the lungs against fluid.
To protect the airway more robustly, we move to the supraglottic airways, led by the laryngeal mask airway, or LMA.
The original classic LMA, introduced by Dr. Archie Brain, was absolutely revolutionary. It's designed to sit in the hypopharynx and create this reliable, low-pressure seal around the glottic opening without having to go into the trachea.
It's less traumatic than full intubation.
Far less. It's easily placed, easily taught, and incredibly useful for emergency airway management, even by non-specialists.
But technology, driven by safety, has pushed us towards the second-generation LMAs. What makes devices like the ProSeal LMA or the iGel superior?
The advancements are directly linked to addressing that aspiration risk. Second-gen devices have a built-in bite block, but the most important feature is the dedicated esophageal drain tube.
How does that work?
This tube sits right over the esophagus and allows fluid, stomach gas, or regurgitated contents to be passively vented away from the glottis and out of the patient's mouth.
So it's not definitive protection, but it's a vastly improved safety margin over the classic LMA.
Precisely. They also generally handle higher inflation pressures, which is necessary for ventilating patients with a high BMI. The clinical trend is undeniable. The evidence suggests these second-gen devices should replace the older ones in routine use because of that safety profile.
But when you need the absolute highest level of security, there's only one definitive solution: endotracheal intubation, or ETT. What makes the ETT the gold standard?
It's all about placement and the cuff. The ETT goes directly into the trachea. Once it's there, you inflate the cuff.
And that cuff seals everything off.
It seals the space between the tube and the tracheal wall. This single act does two things. It ensures all your positive pressure ventilation goes straight into the lungs, and critically, it acts as a physical barrier. It absolutely protects the lungs from aspirating gastric content. The protection is complete.
We also have those specialized tubes, like the double lumen tubes, used in more niche fields.
Yes, those are vital for thoracic and major esophageal surgery. If a surgeon needs access to the chest cavity, they often need the lung on that side to be completely deflated. These tubes allow us to achieve one lung ventilation.
Ventilating the healthy lung while collapsing the other for surgical access.
Exactly. Or, in the case of an infection like an empyema, you can isolate the diseased lung to prevent pus or bacteria from contaminating the healthy one.
Now we come to the moment where the anesthetist's skill is really tested, the difficult airway. Let's put our listener right in the middle of a scenario.
Okay. Imagine you, the learner, are assisting in the OR. Mr. Smith, a 65-year-old man, is rushed in for an emergency bowel repair. His pre-op notes show he has a very small jaw micrognathia and a rigid neck from severe arthritis. You know intubation will be extremely difficult.
What's the single biggest catastrophic risk you have to be prepared for?
The catastrophic risk is not just a failed intubation. It's the compound risk of hypoxia stemming from that dreaded can't intubate, can't ventilate scenario.
If you can't get the tube in, and then you can't ventilate with a bag and mask.
Oxygen saturation plummets. It leads to immediate life-threatening hypoxia, brain damage, or cardiac arrest. The non-negotiable preparation is having a clear plan, a difficult airway trolley, and having advanced visual tools immediately available.
And this is where technology has been so influential. We're moving away from just relying on the line of sight from a traditional laryngoscope.
Precisely. We now have specialized devices. The McGrath blade, the AirTrack, the CMA. These are video laryngoscopes. They have a camera at the tip of the blade that transmits an image to a screen.
So you can see around the difficult anatomy.
You can, and it dramatically improves intubation success rates even when the view is terrible.
But what if even that's not enough? This leads us to the fiber optic solution.
The fiber optic intubating bronchoscope is the final technical solution before you have to resort to a surgical airway. This is where immense skill is required.
How does that procedure work? It sounds incredibly delicate.
It is. The anesthetist first passes the flexible bronchoscope into the trachea under direct high magnification vision. The endotracheal tube is already threaded over the scope.
So the scope acts like a guide wire.
Exactly. And you just slide the ETT down into the trachea. It completely bypasses the need for a line of sight.
And sometimes this whole complex process has to be done while the patient is still awake.
Awake intubation is often the safest choice when you anticipate massive difficulty. The patient keeps their own protective airway reflexes and breathes on their own until that tube is definitively placed. It requires careful patient selection and heavy topicalization of the airway with local anesthetic.
Okay, let's anchor the single most important safety concept from this section. It bears repeating. If you remember nothing else, remember the essential safety difference between an LMA and an ETT.
The definitive cuff protection. That's the high-yield takeaway. And to close out this area, we have to review the potential complications of intubation. Beyond failure, you risk trauma to the teeth, the pharynx, the vocal cords.
You can accidentally place it in a bronchus.
Right, leading to ventilation of only one lung. And long-term high cuff pressure can lead to delayed complications like tracheal stenosis, a narrowing of the windpipe. Airway management is very, very high stakes.
Moving now to the final pillar of the GA triad, muscle relaxation. When we introduce pharmacological blockade to get good surgical access, especially in the abdomen, we create an absolute necessity.
Artificial ventilation.
Right. And we classify these muscle relaxants into two main camps.
Depolarizing and non-depolarizing, based on how they interact with the acetylcholine receptors at the neuromuscular junction.
Let's start with the depolarizing agents, the most famous being succinylcholine. It's infamous for its speed.
It's unique. It acts like acetylcholine, causing the receptor to fire first. This results in brief, visible whole-body muscle twitching, we call them fasciculations, and then complete rapid blockade.
And its advantage is that speed. Quickest onset, shortest duration.
Exactly. That's why it's still used for truly immediate crash intubations where speed is the only priority.
But that speed comes with a huge list of high-stakes disadvantages.
It does. We have to anchor these risks. Suxamethonium can cause generalized muscle pain post-operatively. It causes hyperkalemia, hypotassium, which is life-threatening in patients with burns or crush injuries. It can cause prolonged apnoea in some patients.
And the big one.
And the biggest, most life-threatening risk is its association with triggering malignant hyperthermia, a rare but rapidly fatal condition.
Okay, so contrast that with the non-depolarizing agents. Rocuronium, etracurium, vecuronium. How do they work?
They're competitive blockers. They just occupy the receptor site but don't activate it, so they prevent the body's own neurotransmitter from acting. This gives you a slower onset, but much longer, more predictable activity.
Which means it requires careful monitoring and active reversal at the end.
That's right.
You mentioned a modern game changer, the pairing of rocuronium and sugammadex.
This combination has revolutionized RSI. Rocuronium is a non-depolarizing agent that's been engineered for a rapid onset almost as fast as suxamethonium.
And sugammadex is the breakthrough.
Sugammadex is the breakthrough. It's a cyclodextrin derivative that acts like a chemical sponge. It physically encapsulates the rocuronium molecules in the bloodstream.
So it doesn't wait for the body to metabolize the drug, it just mops it up.
It's a physical, chemical off switch. It rapidly reverses the block. This means we get the rapid onset we need for RSI, but if the intubation fails, we can reverse the paralysis almost instantly.
Which removes the life-threatening risks of suxamethonium in that can't intubate, can't ventilate scenario.
Precisely. It's a massive leap in safety.
And what about etracurium? Why is it favored in certain high-risk patients?
Etracurium is an intermediate-acting agent whose key advantage is its metabolism. It degrades through a non-enzymatic chemical reaction called Hoffman degradation, which is entirely independent of liver and kidney function.
So it's the agent of choice for patients with severe renal or hepatic failure.
Exactly, because other drugs would just accumulate unpredictably. The drawback is that it can risk histamine release, which can cause flushing and hypotension.
Given all these options, why is the peripheral nerve stimulator, the PNS, mandatory when you're using non-depolarizing blocks?
It's for safety and efficacy. The PNS applies a measured electrical current to a nerve, usually the ulnar nerve, and measures the muscle twitch. This lets the anesthetist monitor the depth of the block during surgery.
And, most critically, confirm full recovery before the tube comes out.
That's the most critical part. Extubating a patient who is still partially paralyzed risks life-threatening respiratory failure. You have to be sure they're fully back.
Okay, so when the patient is fully paralyzed, we have to take over their breathing with a ventilator. We have 2 core modes, and understanding the risks of each is essential.
Yes, volume control and pressure control.
Let's start with volume control, or VC. It sounds intuitive. You set the volume you want.
And in volume control, a preset tidal, volume say 500 milliliter, is delivered for every breath. The advantage is you guarantee ventilation. The critical risk, however, is that the airway pressure is variable. If the patient's respiratory system suddenly becomes stiff, their compliance drops, the ventilator will just keep pushing that 500 milliliters, and that can generate dangerously high pressures.
And high pressure leads to barotrauma. Give us a real-world scenario.
The perfect one is laparoscopic abdominal surgery, especially in the steep head-down or Trendelenburg position. The abdomen is inflated with gas, pushing the diaphragm high into the chest. This, plus the weight of the abdominal contents, severely reduces the lung's ability to expand. Compliance is very poor.
So if you stick to volume control, the ventilator might generate dangerously high pressures trying to force that 500 milliliters in, risking a pneumothorax.
Precisely. That's the warning point. Volume control is safe when compliance is good and stable.
Conversely, pressure control, or PC, guarantees pressure safety.
Yes. In pressure control, the ventilator generates flow only until a preset pressure limit is reached, say 25 centimeters of water. The advantage is you prevent barotrauma. The drawback is that the tidal volume is now variable.
So if that patient in Trendelenburg has worse compliance, the machine stops pushing.
And the resulting tidal volume might be insufficient. You could get inadequate ventilation and a dangerous rise in carbon dioxide.
These modes often incorporate PEEP-positive end expiratory pressure. This seems to be the default now. What's PEEP actually doing?
PEEP is profoundly beneficial. Instead of letting the lungs collapse fully at the end of exhalation, PEEP maintains a positive pressure in the airways. This keeps the lungs partially inflated.
And what's the physiological benefit of that?
It prevents the alveoli from collapsing and sticking together atelectasis. It opens up previously collapsed alveoli and maintains a greater surface area for gas exchange. This reduces shunting and significantly improves overall oxygenation.
Okay, let's hit the listener with a check-in question based on that scenario we just set up. If Mr. Smith is undergoing laparoscopic abdominal surgery in the Trendelenburg position, and the anesthetist is concerned about severe restriction on his lung expansion, which ventilation mode carries a higher inherent risk of barotrauma and why?
The answer is volume control. The caution is necessary because that fixed volume has to overcome the high resistance from the pneumoperitoneum and gravity. If you didn't anchor the difference between the guaranteed parameter volume versus pressure and the variable risk pressure versus volume, please take a minute and rewind that section.
We've discussed the complex mechanics of keeping a patient safe. None of this is possible without the continuous, vigilant safety net of monitoring. The source material lists a set of minimum requirements that must be adhered to.
These fall into essential cardiovascular and respiratory categories. For the cardiovascular system, we need continuous ECG monitoring and regular blood pressure monitoring.
For adequacy of ventilation, we rely on 3 key measurements.
Yes. First is the inspired oxygen concentration. Second is pulse oximetry, or SpO2, which tells us how well oxygen is being picked up by the blood. And the third, and arguably the most vital physiological measurement in anesthesia, is the end-tidal carbon dioxide concentration, or ETCO2.
Why is ETCO2 so?
Because it's a direct surrogate for the patient's ability to clear CO2. It tells us immediately if ventilation is effective, if the tube is in the right place, or if the circuit has become disconnected. A sudden drop in ETCO2 is often the very first sign of a life-threatening event, like a pulmonary embolism or a massive hemorrhage.
Beyond the basics, temperature monitoring is key, and for major surgery, 2 additional measurements are recommended.
Urine output gives us real-time information on tissue perfusion and kidney function. And central venous pressure, or CVP, is often used to gauge the patient's fluid status and cardiac preload.
Okay, let's shift gears completely to local anesthesia, the ability to block sensation without causing loss of consciousness.
The chemical principle is brilliant. LAs block nerve conduction by stopping the influx of sodium ions across the nerve membrane. They stop the pain signals. But the key danger is that these agents don't distinguish between sensory nerves and other excitable tissues, which leads us to systemic toxicity.
The complications aren't just local, like an infection. They are systemic, from an overdose or accidental injection into a blood vessel. Where do these effects show up first?
They're dose-dependent, and because the brain is highly sensitive, they usually manifest first as neurological symptoms. Lightheadedness, tinnitus, perioral numbness, then progressing to seizures and convulsions.
And as the dose rises?
It progresses to cardiovascular toxicity, myocardial depression, ventricular arrhythmia, and then cardiac arrest.
Let's anchor the specific drug toxicities, as these are non-negotiable safety facts.
The first and most notorious is bupivacaine. It is highly cardiotoxic. Its long duration is due to strong binding, but this also means it binds tightly to the sodium channels in the cardiac muscle.
So if it gets into the circulation?
It causes treatment-resistant ventricular arrhythmia and cardiac arrest because it's so slow to come off those channels. This is why bupivacaine must never be injected intravenously, especially in a technique like a Beer's block.
And the second unique danger involves prilocaine.
Prilocaine has the least systemic CNS toxicity, which is why it's great for things like Beer's blocks. But in large doses, it produces a metabolite that can oxidize hemoglobin, causing a unique complication called methemoglobinemia, where the blood can no longer carry oxygen effectively.
We often see adrenaline added to a local anesthetic. Why is that?
Adrenaline is a powerful vasoconstrictor. This does 3 things. 1, it hastens the onset of the block. 2, it prolongs the action by slowing washout. And 3, by slowing systemic absorption, it lets you use a higher total dose of the LA itself.
But that vasoconstriction means there are crucial contraindications.
Yes. Avoid it in severe cardiovascular disease or with certain antidepressants. And the classic rule is never use adrenaline-containing LAs in areas with end arteries, the fingers, toes, penis, and nose, because the resulting ischemia can lead to tissue necrosis.
The overriding safety imperative here is non-negotiable then.
Absolute vigilance. Whenever LAs are used, you must have skilled personnel, full monitoring, and immediate access to full resuscitation equipment. Things can go wrong very, very quickly.
Regional anesthesia has become incredibly advanced. It offers clear advantages, especially in high-risk patients.
And it provides far superior post-operative pain relief compared to systemic opioids alone, allowing for quicker mobilization and better patient satisfaction.
The source material really emphasizes the transformation in technique. The old way sounds terrifying.
It was high risk. It relied on crude methods, using anatomical landmarks and trying to elicit paresthesia, touching the nerve with a needle, causing a shock to confirm location. High risk of permanent nerve damage and failure.
So what's the new standard that has improved safety so dramatically?
Ultrasound-guided regional anesthesia. This is the true game changer. The practitioner can actually see the nerve, the tip of the needle, and in real time watch the local anesthetic spread around the nerve.
That visual confirmation must reduce complications dramatically.
It does. It allows for lower doses, reduces nerve trauma, and almost eliminates accidental intravascular injection. Improves both safety and the reliability of the block.
Let's look at some of these specialized techniques, starting with brachial plexus blocks for the upper limb.
The interscalene approach is common for shoulder surgery. It gives great pain relief, but risks blocking the nearby phrenic nerve, causing temporary diaphragmatic paralysis and potentially causing Horner syndrome. For surgery further down the arm, the other approaches are safer.
In the lower limb, we've moved beyond just femoral and sciatic blocks toward hyper-specific blocks like the IPIC block.
The IPIC block is a fantastic example of precision. It targets only the small sensory branches that supply the back of the knee capsule.
And the benefit of that precision?
Minimal motor blockade. Patients who have had knee replacements can still move their quadriceps and ankle. This aids early physical therapy and dramatically improves recovery speed.
We're also seeing a major expansion in fascial plane blocks. Explain the mechanism there.
Instead of targeting a dense nerve plexus, you target the nerves running within the connective tissue or fascial planes. The classic example is the TA block, the transversus abdominis plane block.
And how does that provide pain relief for abdominal surgery?
You inject LA between the internal oblique and transversus abdominis muscles. The LA spreads across that plane, blocking the T6 to L1 segmental nerves that supply the anterior abdominal wall. It's a game changer for pain relief after C-sections or hernia repairs.
Okay, before we hit the central blocks, let's detail a high-risk but high-reward technique. Intravenous regional anesthesia or Beer's block.
Beer's block is for very short procedures on the limbs, mainly the upper limb, like a carpal tunnel release. The core procedure is a masterclass in safety rules.
Take us through the crucial steps.
First, a double tourniquet cuff high on the limb. Second, you exsanguinate the limb, drain the blood. Third, inflate the proximal cuff. Fourth, inject your LA, typically prelicaine, intravenously. Then you inflate the distal cuff and deflate the proximal one. The LA is trapped in the limb.
And what is the single, non-negotiable safety rule about that tourniquet?
The tourniquet must stay inflated for a minimum of 20 minutes no matter what, even if the surgery finishes in 5. That 20 minutes and how long it takes for the prelicaine to bind to the tissues. If you release the cuff too early, the concentrated bolus of LA hits the systemic circulation and causes a massive, potentially fatal overdose.
Finally, let's analyze the central neuraxial blocks, spinal versus epidural. Often confused, but very different.
Spinal anesthesia is a single shot directly into the cerebrospinal fluid. It provides a very intense, rapid block. It's excellent for emergency C-sections, but the sympathetic blockade is also immediate and profound, causing a rapid, marked drop in blood pressure.
That rapid drop requires quick action.
It does. You have to be cautious, especially in patients who are hypovolemic or have poor cardiac reserve.
And how does an epidural contrast with that?
The epidural injection is into the epidural space outside the dura. It's technically more challenging, slower to onset, and has a higher failure rate. But its tremendous advantage is you can place a catheter for prolonged analgesia via continuous infusion.
So the resulting hypotension is slower and better controlled.
Much better controlled. Epidurals are crucial for high thoracic blocks, for upper abdominal or thoracic surgery, because they provide excellent pain relief that facilitates early mobilization and reduces respiratory complications.
We transition now to pain management after the procedure, which is a key component of perioperative care. Multimodal analgesia is the gold standard.
Using different classes of drugs and regional techniques, yes. The foundation rests on paracetamol, NSAIDs, and opioids.
Paracetamol or acetaminophen. It's the essential step 1 on the WHO analgesic ladder.
It's the most common analgesic worldwide. Its excellent safety profile at therapeutic doses is key. Clinically, the big advancement is the IV preparation. Oral or rectal bioavailability can be erratic, but the IV formulation guarantees rapid, predictable therapeutic levels.
Next, NSAIDs. They're used because they're opioid-sparing, which is great, but they carry a serious cautionary tale about their side effects.
The potential morbidities are significant. We worry about four main areas. 1. Bleeding risk. They interfere with platelet function. 2. Gastrointestinal risk. They increase the risk of GI bleeding and ulceration. 3. Cardiovascular risk. They're associated with increased thrombotic events like heart attacks and strokes.
And 4, the renal system.
NSAIDs can cause renal impairment and fluid retention, and they can exacerbate asthma. Using them must always be a careful balance of pain control versus risk.
Finally, opioids weak, like codeine, or strong, like morphine, necessary for severe acute pain, but the trade-off is the side effect profile.
The common ones are nausea, vomiting, itching, and most concerningly, dose-dependent respiratory depression. This is why multimodal analgesia is so essential. It reduces the required opioid dose and mitigates these side effects.
One of the greatest advancements in opioid delivery is patient-controlled analgesia, or PCA.
PCA is fantastic because it puts the patient in control, but with safety limits. The patient self-administers a small bolus dose by pressing a button. The machine is programmed with mandatory lockout times and a maximum dose limit. It avoids the long delays and leads to better pain scores.
Okay, let's look at chronic pain, defined as pain that persists or recurs for more than 3 months. This is far more complex than acute pain.
We first need to classify it. We distinguish between chronic primary pain, where the pain is a disease in itself, like fibromyalgia, and chronic secondary pain, which is a symptom of an underlying disease, like cancer or nerve damage.
The mechanistic classification is even more critical for treatment, right? Nociceptive versus neuropathic.
Yes. Nociceptive pain is standard pain from tissue damage, arthritis pain, or a tumor pushing on tissue. This type of pain typically responds well to NSAIDs and opioids.
But then there's the notoriously difficult neuropathic pain. How is this described, and why is it so hard to treat?
This results from damage or dysfunction in the nervous system itself. Patients describe it in very specific terms: a burning, shooting, electric, or stabbing sensation. Think of diabetic neuropathy or trigeminal neuralgia. The critical distinction is that neuropathic pain is poorly responsive to traditional opioids. Morphine just doesn't work well on it.
This complexity forces us to adopt a holistic framework, the biopsychosocial model. We can't just treat the biology.
Exactly. The model recognizes that chronic pain involves physical injury, emotional distress like anxiety and depression, and social factors. So management has to be multidisciplinary.
Let's talk about the non-pharmacological interventions. They're the backbone of this approach.
They are. This includes physiotherapy and exercise. Crucially, it involves psychological interventions like cognitive behavioral therapy, mindfulness, and structured pain management programs. These programs teach patients self-management and coping strategies.
Since opioids are often ineffective for neuropathic pain, what's the primary pharmacological treatment?
We shift to drugs that stabilize or calm down the hypersensitive nerves. Tricyclic antidepressants have a role, but the mainstays are the anticonvulsants, pregabalin and gabapentin. They specifically target a calcium channel on the nerve terminals and reduce that aberrant electrical activity.
We also have dual-action agents that can bridge the two types of pain.
Tapentadol is a classic example. It's both an opioid agonist and a noradrenaline reuptake inhibitor. So it hits both the nociceptive pain and provides some benefit from a neuropathic component. It's very useful for patients with mixed pain.
And finally, for intractable neuropathic pain that's failed everything else, the key interventional technique is spinal cord stimulation, or SCS.
SCS is a permanent solution for some patients. It involves surgically placing electrodes into the posterior epidural space to stimulate the dorsal column. The electrical stimulation modulates or interrupts the pain signals to the brain. It's highly evidence-based, especially for things like failed back surgery syndrome.
Turning to cancer pain, the goal is slightly different: maximal pain control to maximize quality of life. We rely heavily on the WHO analgesic ladder.
Step 1 is simple: non-opioid drugs. Step 2 introduces intermediate-strength opioids like codeine. And Step 3 utilizes the strong opioids morphine, oxycodone, fentanyl.
When escalating to Step 3, the key is proper titration.
Titration is done using short-acting oral morphine, usually every 4 hours, until the pain is controlled over a 24-hour cycle. Once you find that stable daily dose, you transition the patient to the equivalent dose of a twice-daily slow-release preparation.
And what about when a patient on slow-release meds has sudden, excruciating pain?
That is breakthrough pain. It requires an immediate additional dose of a short-acting opioid, the rescue dose. This is typically calculated as 1/6 of the total 24-hour strong opioid dose.
And finally, the two most common opioid side effects that must be managed proactively in these patients.
Nausea and constipation. Nausea is usually transient and easily managed, but constipation is frequent, persistent, and often debilitating. Every patient starting step 3 opioids must be concurrently prescribed a regular laxative regimen. Failure to do so guarantees distress.
In end-of-life care for intractable malignant pain, we sometimes have to resort to destructive neurolytic techniques.
These are reserved for when all standard methods fail. The most common example is the coeliac plexus neurolytic block for severe abdominal pain from pancreatic cancer. This involves injecting alcohol into the plexus to destroy the pain-carrying nerves. These procedures are permanent and require extremely careful patient selection. We've covered extensive ground, from the history of painless surgery to the nuances of modern chronic pain. To synthesize this deep dive into Chapter 23, here are the 5 anchors we think are essential for your revision and clinical practice.
First, remember the anesthetist is the modern perioperative physician, managing risk and homeostasis across the entire patient journey, pre-op, intra-op, and post-op.
Second, general anesthesia relies fundamentally on the triad: amnesia, analgesia, and muscle relaxation. If one pillar collapses, the patient is at risk, particularly of awareness.
Third, airway safety is non-negotiable. The modern trend favors second-generation supraglottic devices and visualization tools like video laryngoscopes to minimize that catastrophic risk of can't intubate, can't ventilate.
Fourth, local anesthetic safety requires absolute vigilance on systemic toxicity. Anchor the dangerous pairings. Bupivacaine equals severe cardiotoxicity, prilocaine overdose causes methemoglobinemia, and remember, ultrasound guidance is the new standard for regional blocks.
And finally, fifth, chronic pain requires a biopsychosocial, multidisciplinary approach. You have to classify it mechanistically. Nociceptive pain responds well to opioids, but neuropathic pain is poorly responsive and requires nerve-stabilizing agents like pregabalin or gabapentin.
This chapter is full of detailed clinical reference material. We really encourage you to go seek out Chapter 23 of Baily and Love. Specifically, review the tables on drug dosages, the maximum doses for LAs, the equianalgesic opioid potencies. You need to visualize the equipment to truly integrate this knowledge.
We've talked about how far we've come since the brutal days of ether and chloroform, transforming surgery into this controlled, safe experience. If the greatest current challenge we face is intractable chronic neuropathic pain, and we know our best tools, opioids, are poorly responsive.
What unexplored biological or neurological mechanism, maybe something focused on glial cells or central sensitization, do you think holds the next great revolution in surgical pain relief? That's your final thought for reflection. We look forward to diving deep with you next time.